Assalamu alaikum everyone. Good evening, good morning from whatever time zone you're watching. So, because I see a lot of new names here, is my voice clear or do I need to change my place?
Assalamu alaikum, Dr. Kaval, it's clear.
Okay, so we are going to wrap up medulloblastomas today. It's going to be another boring session because they are boring. I can't help that. We are going to have some radiology, some rediscussion of the post-operative staging, the new NCCN guidelines. I'm not going to discuss the guidelines that are in the Greenberg right now. There are a little changes in the newer guidelines. We are going to discuss them. And a quick disclaimer, anybody who is going to attempt the coming theory exam for the FCPS or the clinical exams for the FCPS, you still have to follow the Greenberg guidelines, but you should know what the NCCN changes in 2025 were, especially if you're attempting the clinicals. So, while we are done with the disclaimers, moving on. We are diving headfirst into what happens after we diagnose and we see what the problem is. We know that the case is a posterior fossa tumor, most likely a medulloblastoma. When we reach to that conclusion, then onwards, the GTR remains gold standard. When we're talking about surgical resection, even if we don't know what the pathology is yet, the primary focus is going to be gross total resection. And in the cases where you cannot proceed with a GTR, there is another term which is just a sophisticated way of saying take out the tumor, do not hurt the patient. Right? What is this? This is maximum safe resection. And there is another term which is coined, they are all just fancy names for the same concept, that is cytoreduction. Why do we say cytoreduction? With this word cytoreduction, we mean that we are reducing the tumor burden so that when the patient goes on for the adjuvant therapy postoperatively, there is less burden of tumor cells to manage, right? So, we are very clear that GTR is the gold standard, but usually in the posterior fossa tumors, you are not going to get the entire tumor out because the fourth ventricle floor is often invaded, or even if it's not invaded, there might be adhesions which are adhering it to the tumor. So, in that situation, for example, you are operating on this patient and the patient goes in bradycardia, or your bare monitoring it goes haywire, and your anesthetist tells you that you need to stop, otherwise, you're going to lose the patient. We definitely cannot proceed with a maximum safe resection. We have to take whatever we can take, and then we have to rely on the adjuvant therapy for the tumor control. So, if fourth ventricular floor is invaded, there's no question if you have to terminate the surgery, and a remnant is going to be left there. After you have done the GTR, or let's say near total resection, 30 to 40% patients are still going to require VP shunt. And this is a possibility that should be kept in mind. I don't know what is your individual institutional practice. I'm going to ask all of you about that. But the institute that I worked in, the regular practice at our institute was to put a dandy drain, an EVD, before the surgery or during the surgery before they resected the tumor. And then we used to monitor the output and decide accordingly whether the patient is going to need shunt onwards or not. So, can someone unmute themselves and tell me what their institutional practice is? Anyone?
Assalamualaikum.
Assalamu alaikum, Dr. Javeria.
In our institution, we used to do a shunt, and then 2 weeks later, we did the surgery.
Okay, can someone from any other country volunteer?
So I'm from Liaquat in Karachi, so we do the same thing, that we put in an EVT and then we check the tumor and then see whether we need to put in a shunt or not.
Okay, brilliant. So, yes, that is also a strategy. We used to do preoperative shunting if the patient that presented to us was a child with acute hydro. If there was acute hydro, full-fledged, we are going to see PVL and there was ballooning of third ventricles, patient was with altered level of consciousness, then in those situations, we did used to put preoperative VP shunt and then we waited for like 2 to 3 weeks and then we proceeded for the maximum safe resection. But there are certain situations when the hydro is not full fledged. In those situations, we used to do the EVD. Can someone else volunteer as well regarding their institutional practice?
Yes, ma'am. I am Dr. Mustafa from Bahawal Victoria Hospital, Bahawalpur. In this institute, we also do the VP shunt, and then after that, we go for the posterior fossa resection.
Okay, brilliant. So, one of the reasons where there are two schools of thought, by the way. So, the second school of thought that avoids VP shunt in these patients is the one that follows this, that post shunting leptomeningeal metastasis is a very likely possibility. But Greenberg states that this quoted risk factor, which is almost 20%, is overstated. And there was a time when there were tumor filters were regularly used. Now they are not as commonly used because the actual risk in practice is a lot lesser than this. So are we clear with this? There are two surgical approaches. While this is not a dedicated section for surgical approaches of posterior fossa tumors, I've already mentioned it on the group that we are going to have surgical approaches and posterior fossa anatomy in the coming week. This week, we complete all the clinical topics of posterior fossa, at least the major ones. And from Monday or hopefully Sunday onwards, we are going to have probably 1 or 2 sessions of posterior fossa anatomy and then 1 and 2 sessions of the surgical approaches. So there are two main surgical approaches here. One is telovelar and the second one is transvermian. I'll just draw very briefly, assuming, please excuse my very poor drawing. It's not usually this poor. I'm a calligrapher. Uh, but this is a screen. So this is cerebellum, this butterfly looking thing. This midline thing is vermis. These are the hemispheres. This here is where the brainstem is, and then there's medulla, there's spinal cord, etc., etc. Assume that there is tonsils here. So what ends up happening is when we are going through the transvermian route, we go here. This is the inferior vermis. We split it and then we go in and we land directly into the floor of the fourth ventricle. Whereas when we are doing the telovelar approach, it's an indirect but natural corridor. We have both options. We can either go unilaterally or we can go bilaterally. If a tumor is big enough, we have to go bilaterally. Otherwise, unilateral approach is more than enough. We would have to retract these tonsils here and then follow the arachnoidal plane. We have to go through the microdissection route and expose the tela choroidea and the lateral recess. Through that, we are going to reach the tumor. So this is an indirect approach, but it is a natural corridor. Hence, the morbidity is lower. While this is an unnatural corridor, but this is a very direct approach. It's going to make us land directly on the tumor. But since this is not a direct corridor, sorry, not a natural corridor, this approach, which is transvermian, it's associated with a lot of morbidity. And can somebody unmute and let me know what is the most feared morbidity that is attached with transvermian?
Cerebellar mutism.
Sorry?
Cerebellar mutism.
Cerebellar mutism, ma'am.
Yes, posterior fossa syndrome or cerebellar mutism. They are both distinct entities, by the way. But yes, mutism is a very likely possibility. Apart from mutism, patient might also have balance and ataxia, balance problems and ataxia. Why? Because children are dependent on this region for their balance. Adults are not as much, but children are very sensitive to it. So, what are the drawbacks of tilovelar approach? While it is a natural corridor, but because it's natural, the approach is indirect. And since the approach is indirect, the exposure is a problem. Also, we might need to take out the C1 arch. Sometimes we also have to take out half of the arch of the C2 to get an exposure. Also, if the tumor is closer to the apex here, more in the superior portion, the exposure is going to be a very difficult route with this. So tilovelar is natural. It comes with lower morbidity, but the exposure is difficult. This is technically more demanding. So this is a rough overview. We are going to see it in a more structured manner. The reason I did not show you the slide before is to not overwhelm all of you, because it's just the same thing that we have discussed, written in a very organized manner. So, tilovelar and transvermian, it's the natural plane. This involves a vertical incision. The surgical corridor is created by opening the telocoroidea and the inferior medullary velum, whereas here we are creating a direct midline split. Exposure is excellent for both, but this more when there is floor of the fourth ventricular involvement or where the tumor is migrating outwards via the lateral recess. This is excellent for superior or rostral tumors or those that are towards the higher side in the fourth ventricle. We have already discussed the neurological risk. Vascular safety, yes, this is a big question. Since we are taking away and we are retracting the tonsils, it gives us a very good view of pica. And since we get to see the pica, the chances of injuring it are way less. Whereas here we are going to injure the midline vermian muscles during the split. Also invasiveness, but it's the same thing as the primary technique. Tilovelar is a natural corridor, whereas transvermian is obviously invasive and involves resection. I think you all know this. We are going to have a proper session on this with the diagrams and maybe a few videos so that you can understand it easily. So these are the potential issues. We know that tilovelar approach is going to require a higher level of surgical technique. The learning curve is very steep. Not everybody can do it. And there is going to be a significant amount of microdissection and arachnoid plane involvement. Rostral reach is limited. We have already discussed that. Tissue trauma is very minimal, but there is going to be a problem since we are retracting the tonsils. It might lead to postoperative edema, and the space not be significant enough to compensate the tonsillar edema, which may lead to poor prognosis in the patient. Whereas in the transvermian approach, it may stress the vermis or the dentate nuclei. Am I clear? I think this was pretty simple and not as boring. Okay, moving on. So I just left this here as a reminder that if somebody found this quick paced, then we are going to have a proper session on the surgical nuances in anatomy, everything. So, medulloblastoma versus ependymoma. I have some very interesting images. Can somebody volunteer? Anybody?
Yes, sir.
Okay,
Yes,
Dr.
ma'am.
Mustafa. I'm so happy to hear you volunteering every day. It's going to help you really, really well in your day-to-day clinical practice.
Thank you very much, ma'am. Thank you very much. The image on my left side is this is a CT scan brain plane showing the axial cut of the base of the brain in which there is an iso dense lesion at the level of the posterior fossa, which is causing effacement of the fourth ventricle towards the right side, and it contains calcifications as well and causing gross hydrocephalus as well.
Okay, and on the other image?
The image on my right side is this is the CT scan brain plane showing the base of the brain, and there is a hyperdense lesion, heterogeneous hyperdense lesion at the level of the posterior fossa, causing effacement of the fourth ventricle towards the right side, and also associated with gross hydrocephalus because the temporal horns are visible.
That's right. I am really, really happy to see how much you have evolved in your radiological interpretation. And yes, you are right. So, what do you think? Which is which? Which is a medullo and which is an ependymoma?
Yes, ma'am. The image on my left side is the medulloblastoma because it contains less calcifications because calcifications are only 20% in medulloblastoma.
So, do you think this is
And
calcification? What do you think this is?
I think it may be the necrosis because it may be the cystic presentation of
If it
ependymomas
was
because
cystic, let's say, what color would it be? It would be black, right? I'm giving you
it
a
will be,
clue by drawing it. What is this?
this is
Yes, that's
hemorrhage.
Hemorrhage, ma'am.
hemorrhage. Yes,
Exactly, this
hemorrhage.
is hemorrhage.
Hemorrhages, yes.
So, if it was
The-
cystic, but a very good shot at the rest of the radiology, Dr. Mustafa. And since I have seen you grow from the very first session, I'm really, really happy with how much you have uh, gotten better with the radiological interpretation and how you narrate it. So,
Thank you.
this is hemorrhage, and we see that I don't see any cyst in there, but there is gross hemorrhage within the tumor. Whereas on the other side, we see that it's an isodense lesion with some patchy hyperdensities, most likely representing calcifications. But you're right about the first image being the medulloblastoma and the second image being the ependymoma. What I
Yes, ma'am.
wanted to show you was that sometimes we do have this interpretation of ependymomas growing from the floor of the fourth ventricle, whereas the medulloblastoma is growing from the roof of the fourth ventricles. This is something we learned very early on during our residency. This is the same thing we are taught in the rounds, in the classes, everywhere. And we often miss that there are types of ependymomas that also grow from the roof of the fourth ventricle. They also grow from the lateral recesses of the fourth ventricle. So, the involvement of the floor of the fourth ventricle is not always important. And if you see here on the second image, let me change the color. You see that the fourth ventricle is more or less effaced on this side, and the tumor is coming from here, most likely involving the roof or the lateral recess, and it's compressing and effacing the fourth ventricle on the opposite side. So, based on this single radiological interpretation, we cannot say which is which. Let me move on to the next slide. Okay, so can anyone else volunteer?
Hello, ma. Ma, can I ask a question?
Yes, Dr. Ken.
Based on the last picture, please, can you go back?
Yeah, I went.
So based on what you were saying, ma, could we call this cleft on the right side as a CSF cleft where you initially marked?
Yeah, are you calling this the CSF clefts?
Yes, there.
No,
Could
we cannot
on
call
the
them
left
the
side?
CSF clefts. This is the fourth ventricle. This is an effaced fourth ventricle that has been displaced towards the opposite side. This is not a CSF cleft. A
Okay, ma,
CSF
thank you.
cleft is the collection of CSF in the subarachnoid space apart from the ventricles.
Okay, ma, thank you.
So we move on to the next slide. Can someone else volunteer? No one?
Okay, I will do.
Yes, Dr. Sen.
This is T2 axial image of MRI showing the level of the posterior fossa, hyperintense lesion occupying fourth ventricle with mass effect. I see extension to the left CP angle.
Yes, there is a very significant extension towards the lateral recess and then the CP angle. So which lesion do you think this is? Is this a medullo or is this an ependymoma?
Radiological only, I will see it's it's ependymoma, but I will
Why do you
consider the
think
age
that?
of the patient.
Why would you say
Okay.
that?
There's no calcification. That's first of all.
Mm-hmm.
Okay, I think there's a small cystic component.
Yeah,
The
there's a
lesion.
small cystic component here.
Yeah.
And yes, you're right. This is an ependymoma. And a very good feature to remember regarding ependymoma is that it shows plasticity. What do you mean by plasticity? We mean that a lesion, it conforms the shape of the ventricle and then it sort of expands around and leaks around the ventricle. Imagine silicone. How silicone molds itself around a cavity, that is how ependymoma is. Otherwise, medulloblastoma is a very well circumscribed lesion. And
you mean by
yeah, Dr.
you
Sen?
mean by the other word, it's expansile, not infiltrative?
No,
am I getting
ependymomas can also be infiltrative.
True, or
Ependymomas can also be infiltrative. Plasticity is a morphological feature. Plasticity would, let me draw here on the other side. Just give me a minute. So this is how a well circumscribed lesion is, okay? And imagine that this is the ventricle.
Excuse me,
Yeah, Dr. Sen?
I have a bad connection, so the last sentence I have been missed. What do you mean by plasticity?
Okay, just
you mean
give me
it's expansile? Okay.
Okay, just give me a minute. So this is a ventricle here. This is also a ventricle. There are two lesions. This is one lesion, right? And then there is this lesion that is slightly going like this, molding around the shape of the ventricle, not maintaining its actual true shape. So this one is well circumscribed and it's not also showing plasticity, because to show plasticity, it would mean that the tumor is molding around the shape of the ventricle or whatever space it is in, and then also leaking out and expanding. It does not have to be infiltrative or expansive. Somebody is writing something. Yes, Dr. Fatma. WNT activated medullo also shows plasticity, but plasticity is more of a feature in ependymomas, whereas when we talk about medulloblastomas, the general behavior is that they are well circumscribed. Plasticity can be a very small feature. I have a picture of WNT. I'll show it ahead. Let me clear. I think the one thing that you will get from this radiological discussion is it's usually not as easy to differentiate medulloblastomas and ependymomas just on the basis of radiology because a lot of features overlap. So, can someone else volunteer for these sections?
Okay, someone else. Okay, thank you.
Thank you, Dr. Sen. I think your internet is patchy because every time you talk, I hear only half of the sentence.
Yes. I have a bad connection, unfortunately.
Okay, that's okay. That's completely okay. So, can someone volunteer and narrate whatever the reason
Dr.
these
Pawan,
images? Yes, Dr. Sana.
Thank you. On my right side, this is a T2 weighted axial MRI of brain showing a mixed intensity lesion at the level of the bones, and there is some cystic areas inside the lesion. And the other image is T1 weighted image sagittal section showing a lesion at the level of the post contrast. Okay, this is a post contrast image, and this is showing a lesion at the level of the fourth ventricle, and there is an area of central uh, necrosis or non-enhancing, and it is non-enhancing lesion, and there is some downward herniation of the tonsils as well, and upward. Thank you.
I saw that you were about to comment on the hydrocephalus, but then you realized it was not visible and you stopped right on point. So that's very good growth. I'm very happy with both Dr. Sana and Dr. Mustafa. And seeing you people grow it's very gratifying because it makes me feel that okay, this all is not going to complete waste. So yes, you were spot on about the radiology. Why I included this image here when it already clearly showed that this is a medulloblastoma? Because it showed the origin here very clearly. We see that this is arising from the roof of the fourth ventricle, and the fourth ventricle itself is effaced and maybe displaced, not exactly displaced in this image, but we see that it is effaced and there is it's touching the brainstem. It's also causing some displacement of the brainstem, and there might be some invasion going on in here, but obviously we cannot we cannot say that just on the basis of radiology. So someone is writing something in the chat box.
I have one comment. This is a typical picture of medulloblastoma.
Yeah.
I would say it's medulloblastoma just for one thing, just that the surgical MRI shows that the patient is child. So other than this, it has a cystic and solid component.
Yeah.
The other feature you mentioned, yes, there's no plasticity, so it's not filling the hole, the fourth ventricle with leaking. If I am getting you correct.
Yeah, that's right. But it can also be ependymoma as well, because ependymoma does have a lot of cysts, and it can also present with this type of image. It's really, really difficult to identify with surety which is which. So it could have been ependymoma as well, had you not seen the sagittal image. And even with this sagittal image, by the way, this can be ependymoma. So, which one is this? A very quick guess. And why do you think it is the particular tumor that you are talking about? Which is which? Is whether this is medulloblastoma or this is ependymoma?
Ependymoma, I would say.
Why?
The same, the origin clearly from the roof of the fourth ventricle, and there is a small cystic component within the lesion.
That's right. And what is it? What else is it showing? Dr. Fatma has written in the chat box, so I'm assuming all of you have seen.
Plasticity.
Yes, this is showing plasticity, Dr. Ken. This is an excellent example of what plasticity is. And you can see that it's conforming to the shape, and then it's also leaking sort of downwards. So when you read the word plasticity, always think of silicone. And we are running late. I don't think I would be able to complete the presentation. Let's complete the radiological differences at least, and then we can probably complete the rest of the session tomorrow, inshallah. So this is a rough comparison. These are not absolute features, apart from the calcification, yes. So medullos are usually hyperdense. Why they are hyperdense on CT? Because they are densely cellular. We have discussed this yesterday as well. These are densely cellular lesions, and that is why they appear hyperdense, whereas ependymomas are usually isodense to hypodense. Just give me a minute. Okay, I'm sorry for the interruption. So, calcifications are very rare in medulloblastomas. We discussed that yesterday as well, 10 to 20%, whereas ependymomas show a lot more calcifications, sometimes up to 50%. They are chunky, coarser, Medullos can have cysts. Ependymomas can have cysts as well, but ependymomas usually have bigger cysts. They are more of a visible feature in comparison with medullo. But again, overlap is completely possible between both of them. Shape, as I've already mentioned, medullos are rounded, spherical, usually well circumscribed. Ependymomas are also well circumscribed, but they are pliable, irregular, they tend to fill the ventricle and conform to its shape. On the MRI brain comparison, T2 signal is iso to hypo on medullo, but it can be hyper as well. Ependymomas usually are hyperintense, but on T2 they appear as heterogeneous. And why is that? Because there are calcifications, there are cysts, and that is why they can appear heterogeneous on T2. DWI, we discussed it very thoroughly yesterday, that they are very bright on DWI because there's marked diffusion restriction, whereas in ependymomas there's restriction, but it's milder in comparison. Medullos enhance avidly. Ependymomas also enhance avidly, but it can be heterogeneous. But medulloblastomas can also be heterogeneous. So these are just generalized features. They are not absolute. CSF seeding is a very common presentation of medulloblastomas in comparison with ependymomas. Let me see. What's the next slide? So, Dr. Fatma made a point in the chat box and that WNT activated medulloblastomas also show plasticity. That's right. They also show, just let me change the marker. They also show the movement towards lateral recess. Sometimes they also involve CP angle. If there is a lesion which is going towards the CP angle or the lateral recess, and you are doubting that it's more likely to be a medulloblastoma, always think WNT activated. SHH are typically hemispheres. You see a cerebellar hemisphere, and SHH are most likely going to be hemispherical lesions, whereas groups 3 and 4, they are usually midline, often presenting with severe hydrocephalus and a high incidence of metastasis, especially group 3. We have discussed it very thoroughly. Group 3 is one of the more wilder groups. So you see a lesion in the midline, you think groups 3 and 4. You see a lesion in the cerebellar hemisphere, you think SHH activated. You see a lesion which is going towards the CP angle or the lateral recess, then you think WNT activated. Have I made myself clear?
Yes.
Yes.
So
Yes.
this is an example of WNT activated medulloblastoma, and you see that it is going towards the CP angle. And yes, somebody asked the CSF cleft sign. This is the CSF cleft sign. Do you see this? This here is the CSF cleft sign.
Yes. Yes,
You
ma'am.
can
Yes, ma'am.
appreciate this on T2 weighted images, and this is usually accumulation of CSF in the subarachnoid space around the lesion. Why is that? Because there is pressure effect and the CSF is not moving freely around the lesion, and that is why we get a CSF cleft. So usually this is a feature of extraaxial lesions, but it can also present in intraaxial lesions sometimes, like medulloblastomas. I think I'm going to end this session today here because post-op risk stratification is a long discussion in itself. So let's move on to the last slide. That's a wrap for today. And any feedback, any questions, they're all welcome. This is an open forum. You are learning, I am also learning, and it's a mutual learning experience, inshallah.
Yes. I have a question, please.
Yes, Dr. Kingsley.
Okay, thank you very much for the wonderful discussions. Okay, please, I would want you to throw more light on the previous MRI images to explain more. How do you know whether a lesion is arising from either the floor or the roof of the fourth ventricle? What are the characteristics finding? And then
Okay.
the first
You're talking
CT
about this
scan.
one?
Hello. Yes, exactly. Yeah, what are the things you see that will make you know that it is arising from the floor or the roof of the ventricle?
Okay, so you see that
Then,
I I am not sure if I understood your question correctly. Let me take a shot. You see that the lesion is more or less attached here, and if I zoom this here, just let me zoom this in again. So if you see here, there is a very small cleft behind this yellow arrow that is hypointense. It's very small, but it's hypointense. If I'm going to draw it in, it's not going to be as visible. This space here is still empty, which means, and a similar cleft I cannot see here. So when I can't see it here, but I can see it here, that means that the lesion arose from this point and then it grew in this direction, causing the compression of the fourth ventricle while still leaving a very small rim. Can you appreciate this small black line, Dr. Kingsley?
yes, I can. I can.
Okay. Okay, so that's how we know that the lesion is more or less arising from the roof of the floor of the fourth ventricle, not from the floor.
Okay, thank you very much. And then the next question is the first CT scan we showed. You are talking about that it may not be easily possible to distinguish between medulloblastoma and then the ependymoma. Then looking at the image, that the second image, that's the one taken at the base.
This one?
It seems to have a more robust perilegional edema on that one. No, not this one, the first CT scan.
The first one.
Yes.
I think it was the first one.
Exactly
This was the
this.
first one. Yeah.
Can you judge based on the degree of the perilegional edema on the one taken at the base compared to that on the right? This may be a higher grade lesion. So that one taken at the base, probably thinking about a medulloblastoma, as against that on the right as ependymoma. Can you
You
judge based on
cannot
that?
solely judge just on the presence of edema. Edema can be present in both the lesions. If the ependymoma is a higher grade, it might have more edema. Also, it also depends how long the lesion has been there, how much of the pressure effect it is putting on. So there are a lot of factors. You cannot just differentiate between both of them only on the basis of the edema.
All right, thank you.
Okay, everyone, I think I have been making one single point again and again throughout these sessions. Radiology usually follows a general rule. There are some general rules for the lesions. We see them, we process those general rules through our head, and if we look at them through those rules and we make an impression, okay, this is going to be this. But radiology is not absolute, and that is why always keep a possibility in your head that this might be something else. Radiology is never going to be absolute. Maybe after a widespread use of radiomics, that's a different thing. But so far, the common radiology that we have right now, without the AI, it's not going to be absolute. It's always going to have some of the loopholes and overlapping features. And clinical picture correlation is always going to be needed. There's a reason radiologists write that correlate clinically. So thank you so much, everyone. This is a wrap. I'm realizing that our sessions are getting longer and longer, but that's okay. We are going to continue this tomorrow and hopefully wrap this up once and for all. Thank you so much.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, Allah Hafiz.
Thank you. Allah Hafiz.